Good afternoon, everyone, and thanks for joining us. Today, we're talking about something many practices are already familiar with, Pharmacy First. Not so much about what it is, but how to make it work consistently in everyday practice. Most teams can spot the obvious referrals, but when phones are really busy, reception teams are under pressure, and demand is consistently high, it's easy for opportunities to be missed. That's where Pharmacy First can sometimes become an occasional option rather than part of the normal workflow. Over the next 30 minutes, we'll look at what we're seeing in practices, which patient requests are often suitable for referral, and what the early data is telling us, and how digital referrals can help make decision-making quicker and more consistent for your teams. I'll now hand you over to Michelle, who will be taking you through today's session.
Thanks, Lauren. Thank you. Hi, good afternoon, everybody. Thank you so much for joining today. We really appreciate it. My name is Michelle Goldswain, so I'm the account management lead here at Silicon Practice. So I'm going to be taking you through today's session. I do appreciate that taking 30 minutes out of a busy clinical or operational day is not always easy. So particularly given the pressures that most services are currently working under. So thank you so much for taking the time. We are all acutely aware that the currency of time is perhaps the most precious resource in primary care today. So what I'd like to cover over the next 30 minutes so what we'll do is take a practical look at Pharmacy First. So not just what it is in principle or on a policy document, but how it actually functions in this white heat of the day-to-day practice. What we want to discuss is what difference it can make realistically when it's used consistently rather than as an occasional afterthought. So many of you will already be familiar with the programme itself. It's been part of the national conversation for some time now. However, we often see across various practices, PCNs, it's a significant implementation gap. The space between what Pharmacy First is designed to achieve at a sort of ministerial level is what actually happens when a patient calls that surgery at 8:01 a.m. on a Monday morning. So the focus today is really on that gap, and we're going to explore the scale of demand that practices are currently drowning in, how Pharmacy First fits into that specific picture, what the real world data is showing us so far, and then most importantly, why the impact can sometimes be inconsistent or underwhelming. Excuse me. So towards the end, we'll have a look at what helps close that gap, specifically focusing on how we can support administrative and clinical teams to make quick, confident and consistent decisions. This is less about introducing a sort of new thing and more about making an existing tool sharp enough to actually cut through the workload. Before we get started, I just wanted to do a little bit of housekeeping. So you should see, hopefully, a Q&A box on the left of your screen. So feel free to submit any questions or observations there at any point during the session. So just so you don't have to wait until the end. We have a dedicated Q&A session at the end, so we'll address any of those questions, but at least, capturing your thoughts as we go through, we can make the most of that discussion later on. Okay. So let's start with the reality that most practices are operating within. It's important to ground our discussion in the data of the here and now. So demand across primary care remains at record highs. To put that into perspective, NHS England data confirms that over 30 million GP appointments are now delivered every single month, and that is a staggering volume of activity. To visualize that, it's the equivalent of the entire population of the country visiting a GP twice a year, every year. Now, this isn't just busy, this is a system operating at the absolute limit. Alongside this volume, we've seen a fundamental shift in patient expectations. In the sort of Amazon Prime era, the patients expect quicker access, more convenient digital touchpoints, and immediate outcomes. While this is a logical evolution of consumer behaviour, it creates an immense friction point when applied to a clinical system where the workforce capacity hasn't grown at the same rate. So we are facing a chronic, capacity demand mismatch. So what happens in the real world? So this demand is managed at the front door. So your reception teams and care navigators are essentially the air traffic controllers of the NHS. They're making rapid fire clinical and operation decisions in seconds. These aren't decisions that are made in a quiet office with a cup of tea. They're made while the phones are ringing off the hook and patients are queuing at the desk and clinicians are asking for updates. If we look at the numbers, roughly 7% of a practice list seeks an appointment in any given week. For a standard practice of 10,000 patients, that is 700 requests. That's 700 individual moments of decision-making. If even a small percentage of those decisions are suboptimal, the backlog of inappropriate appointments begins to choke the system, preventing those with complex chronic needs from getting the care that they require. So Pharmacy First represents a fundamental pivot in the philosophy of primary care delivery. Historically, the GP was the default for everything, whether it was a complex multi-morbidity case or simple case of impetigo. The patient journey almost always ended up in a consultation with a doctor. This model is no longer sustainable, so Pharmacy First introduced an alternative, high-quality clinical pathway where patients are seen by highly trained pharmacists, clinicians who have spent 5 years studying medicines and pathology. This is part of the wider, fuller stocktake vision, making better use of full clinical workforce. So we have to stop thinking of a community pharmacy as a retail outlet that happens to dispense pills and start seeing it as a clinical extension of the GP surgery. Community pharmacies already deliver tens of millions of consultations annually. They are accessible, they're in the heart of the community, and they often have longer operating hours than the local surgery. So by formalising this into the Pharmacy First pathway, we're not offloading work, we are right-loading it. So we are ensuring that the patient is seen by the most appropriate clinician for their specific need at that specific time. So when we look at the clinical scope of Pharmacy First, it's clear that this is designed to hit the high volume, low complexity heart of general practice. These are the kind of bread and butter cases that fill up your morning triage list. So we're talking about things like acute sore throats, uncomplicated urinary tract infections in women, ear infections, infected insect bites or impetigo and shingles, acute sinusitis. If you audit your last 1,000 appointments, a significant percentage will fall into these categories. And these are conditions that will follow very clear clinical protocols. They don't require the diagnostic detective work that a GP specialist training is designed for. They require efficient, evidence-based intervention. By identifying these 7 clinical pathways, the NHS have essentially handed general practice a relief valve. The potential for impact is not in the complexity of the cases, but in the sheer frequency. If we can move the routine out of the surgery, we save the surgery for the complex. I want to pause on a very important distinction. So Pharmacy First is not just a reassurance service. There has been a persistent myth that sending a patient to the pharmacy is just signposting for advice, the classic sort of honey and lemon suggestion. That is not what this is. So Pharmacy First allows pharmacists to provide prescription-only medicines via patient group directions where clinically indicated. And this is a game changer. It means that the patient journey results in a resolution. If a woman presents with a UTI that meets the criteria, she leaves the pharmacy with these antibiotics she needs. If a child has an ear infection, they are assessed with an otoscope and treated. From a system-wide perspective, this is the holy grail. So why is this? Well, it's because the pharmacy can resolve the issue. The patient doesn't bounce back to the GP 48 hours later because they just wanted a prescription. By providing a clinical outcome at the first point of contact, we're effectively deleting that demand from the GP's future workload. So let's have a look at the plumbing of the system and how referral actually works. The process is designed to be digitally integrated. So it starts at the practice front door, whether the patient calls or if they use online triage tools. The care navigator identifies the symptoms as falling under the Pharmacy First criteria. So instead of booking a GP slot, they trigger a digital referral. So this is a warm handover. The pharmacy receives the patient's details via a secure electronic platform. They don't just wait for the patient to show up, they're able to proactively manage that referral. So the consultation can be face-to-face or in some cases via video or phone. Once the consultation is finished, the loop is then closed. So the pharmacist is able to record the outcome and a notification is sent back to the GP surgery to be filed in the patient record. This ensures continuity of care. So the GP knows exactly what's happened, what's prescribed, and what the safety netting advice was. So it's a professional clinical handover, not a sort of go down the street and ask the pharmacist suggestion. So what does this feel like for the person that actually matters? That's the patient. In most cases, the feedback is overwhelmingly positive. The number one complaint in primary care today is access. So I can't get through on the phone, or I have to wait 2 weeks for an appointment. Pharmacy First solves this. So many patients can be seen by a pharmacist within hours and not days. Patients value the convenience. They can go into a pharmacy near their work or their home. They don't have to navigate complex phone queues or sit in crowded waiting rooms. They get 5 to 10 minutes of dedicated time with a clinician who is an expert in their field. So when we look at the data on patient satisfaction, people who use these pathways once are highly likely to use, are then highly likely to use them again. They realise that the doctor isn't the only answer and the clinician is. So by improving the speed of resolution, we can improve the overall trust in the local healthcare system. So we're now several years into the implementation of Pharmacy First, and the data is beginning to paint a very clear picture. Across the country, we've seen millions of consultations delivered. This is no longer an experimental pilot. It is a proven pillar of the NHS long-term plan. The data shows that the vast majority of these consultations result in successful clinical outcome without the need for a GP follow-up. In areas where the pathway is used aggressively and consistently, we are seeing a measurable stabilisation in the GP wait times for other conditions. We're also seeing high levels of compliance with clinical protocols by pharmacists. However, the data also reveals something else, variation. In some postcodes, the service is flying. In others, the referral rates are nearly zero. So this tells us that the problem isn't the service itself, it's the referral behaviour at the practice level. So, the capacity is there, the funding is there, and the pharmacists are ready. So the bottleneck is at the point of triage. So let's talk about the size of the prize. So if we look at the 7 clinical pathways and add in the existing minor illness services, clinical modelling suggests that up to 1 in 5, so 20% of all GP consultations could potentially be managed by a community pharmacist. So if we think about that for a second, if you could instantly reduce your daily triage list by 20%, what that would do for your staff morale. What would it do for your ability to manage patients with complex diabetes, frailty, or mental health crisis? This is the equivalent of adding several hours back into a GP's day, every single day. So it's not just a marginal gain, it's a structural shift. For a typical PCN, this represents thousands of hours of clinical capacity reclaimed over a year. The question isn't whether the demand is there. The question is, why are we still holding on to it at the surgery? So let's put some hard numbers on this to make it more tangible. So imagine a standard practice with a list size of 10,000 patients. So as we discussed, they're getting roughly 700 requests a week. If that practice achieves the modest 15% referral rate to Pharmacy First, that's 105 patients a week. And that is 105 appointments that don't need to happen in the surgery. In terms of GP time, if each appointment is 10 minutes, that's 1,050 minutes, so 17.5 hours. That's effectively four full GP sessions worth of time saved per week. And the crucial bit is that the capacity is created without having to hire a new staff member. You aren't paying for a locum. You aren't trying to recruit a new partner in a difficult market. You're simply utilising the sunk cost of the community pharmacy network that already exists, and it's already funded. So the benefits of this then ripple out far beyond the GP consulting room. So first, let's have a look at the reception team. Their job is incredibly stressful, and giving them a clear, sanctioned sort of yes for a patient request, yes, I can get you seen at the pharmacy today, is a lot more rewarding than saying, no, we've got no appointments left, call back at 8 a.m. tomorrow. And that's reducing the conflict at the front desk. Secondly, for practice managers, it provides a way to manage the 8 a.m. rush. By having a reliable pathway for common ailments, you can smooth out that demand curve across the day. And finally, for the patients, it creates a sense of a joined up system. So when the receptionist says the pharmacist is an expert in this condition and they're waiting for your referral, this builds confidence and it moves us away from the sort of gatekeeping and towards care navigation. It changes the culture from one of scarcity to one of resourcefulness. If it's this good, why isn't every practice doing 100+ referrals a week? So we'll have a look under the hood and we see that, you know, there's islands of excellence surrounded by a sea of inconsistency. You might have one receptionist who is a champion for Pharmacy First and refers every suitable case. And then there may be a colleague on the next desk who perhaps might be a bit newer or they haven't had the same training and they might default to everyone being on the GP list. This variation is the enemy of efficiency. So if the pathway is only used 20% of the time that it could be used, the surgery still feels the pressure of the other 80%. So the system doesn't feel any lighter because the volume is still hitting the GP's screen. Furthermore, if patients only get offered Pharmacy First occasionally, they're not going to learn the sort of rules of the game, if you like. So they keep calling for a GP because that's what they've always done. And to change that behaviour, we need to be 100% consistent in our own behaviour. It's important not to blame the staff for this inconsistency. We have to look at the environment. So triage is high stakes, it's high speed, it's a high speed task. And when a staff member is on the phone, they are balancing three things. They've got risk. Is this actually something serious that I might miss? Time, you know, if I've got 12 people in the queue, I need to finish this call. And then path of least resistance. So it's easier sometimes to just book a slot than to explain a service to a skeptical patient. Under pressure, the human brain will default to safe and familiar. The GP appointment is the ultimate safety net. Staff may be unsure if a specific rash fits the Pharmacy First criteria or if the patient is the right age. Instead of checking the manual or the website, which takes time, if they, you know, which they don't have, they simply book the GP appointment. This sort of decision fatigue is the primary reason why Pharmacy First isn't reaching its full potential. We're asking the staff to perform a complex clinical triage role without the real-time tools they need to do it confidently. There is a massive difference between signposting and referral, and we need to be very clear about this. So signposting is what we used to do. I'm sorry, we have no appointments, but you could try going to the pharmacy. And this is a disaster for the system. The patient feels rejected, the pharmacist has no clinical context, the GP has no record of the interaction, and often the patient will go to A&E instead because they don't feel looked after. Referral is a formal clinical handover. The staff member says, I'm referring you to the pharmacy now. They'll have all of your details and they'll contact you. This is a professional action and it carries the weight of the practice's authority. When we signpost, we lose the patient. When we refer, we manage the patient. So Pharmacy First is built on the referral model. If your staff are just sort of suggesting the pharmacy, you're missing out on the data, the funding, and the clinical safety that the formal pathway provides. Small gaps in a busy day add up to massive deficits over a month. If your team misses just 3 appropriate pharmacy first referrals a day, that's 15 a week. So that could be 60 a month. And that is 60 GP appointments wasted on conditions that could have been resolved elsewhere. Think about those 60 people. Some of them may have waited 3 days to get that appointment. And during those 3 days, their condition might have worsened, or they might have called the surgery 3 more times to check the status. Consistency is the multiplier. So if you increase your referral rate by just 5%, the cumulative effect of your available capacity is profound. It's like interest on a bank account, it compounds. The more you use the pathway, the more the routine demand moves out of the surgery, and the more the surgery becomes a calm environment for complex care. So what is the gold standard that we're aiming for? So first is consistency. So every patient, every time, it shouldn't matter which staff member answers the phone, the outcome for a sore throat should be the same. Second, confidence. Your reception team should feel like care navigators in the truest sense. They should know they are doing the right thing for the patient and for the practice. And third is embeddedness. So pharmacy first shouldn't be a project or a pilot. It should be the way that we do things here. So it should be as natural as breathing, for example. So when a practice reaches this state, the morning rush feels different. There is a clear process for sorting the simple from the complex. The GP starts their morning clinic seeing patients who actually need the specific expertise. So that's the goal. And this is exactly why we have developed referral flow. We realized that we couldn't just give staff more training or more manuals, and they don't have time to read manuals while a patient is shouting at them at the phone. They need a co-pilot. So referral flow is a decision support tool that sits right at the point of contact. So as the staff member talks to the patient, the tool guides them through the specific criteria for pharmacy first. Is the patient over 18? Is it an uncomplicated UTI? Are there any red flags? It's not about replacing human judgment, it's about supporting it. It takes the cognitive load off of the staff member, it removes the fear of making a mistake, and it makes the right decision the sort of easiest decision. When you implement a structured tool like referral flow, the transformation is immediate. So, for example, the speed, handling a request becomes a lot faster because the logic is laid out for you. With accuracy, you're significantly less likely to refer an inappropriate patient, which then frustrates the pharmacist, or miss an appropriate one, which will frustrate the GP. Auditability, you can see exactly why the decisions were made. Training, so you can, any new staff can become effective care navigators in days rather than months. So the expertise is baked into the software. Essentially, we're moving from memory-based medicine to a systems-based medicine. We're ensuring that high standards of the practice are maintained on every single call, regardless of how busy it is. And finally, let's step back and have a look at why this matters to the future of the NHS. The current model of GP as everything is breaking. We're seeing burnout, early retirements, and a crisis in retention. To save general practice, we have to allow general practice to focus on what it does best. So complex, holistic, longitudinal care. Pharmacy first is a vital part of the solution. It connects the spare capacity in our high streets with the excess demand in our surgeries. It creates a more resilient and more responsive system. When we make pharmacy first work, like really work, we aren't just fixing a referral pathway, we're building a model of primary care that can actually survive and thrive in the 21st century. It's about creating a system that works for the staff, works for the taxpayer, and most importantly, works for the patient. And to wrap up, I want to leave you with 5 key points. So demand is not going away. have to change how we manage it rather than just trying to work harder. Pharmacy First is a clinical solution. It's about resolution and treatment, not just advice. The potential is huge. So 20% of your current workload could potentially be handled via this pathway. And consistency is the secret sauce. So variation is what kills the benefits of the system. Support is essential. We cannot expect staff to be perfect care navigators without giving them the digital tools to succeed. The capacity you need it's already there. It's sitting in the pharmacy down the road. We just need to build the bridge to get the patients there consistently. And so I'll stop there. So we're very happy to take any questions that you have, or perhaps you've had any specific challenges with referrals, or you've seen some great successes that you'd like to share. I'm also interested to hear how your care navigators currently feel about the triage process. So yeah, the floor is yours.
Thank you, Michelle. That was great. We have had quite a few questions come in.
Okay.
So we will try and tackle as many as we can before the session ends. So yes, just to let everybody know that this webinar is recorded, and a recording will be sent out to everyone that has attended today. So yeah, don't worry, we'll be getting a recording of this. Right, so first question we've had, what happens if a patient is referred to Pharmacy First for something like a sore throat, but the pharmacist identifies a red flag that requires an urgent GP review? Is there a fast track process for them to come back to us, or do they go back to the start of the 8 a.m. phone queue?
Yeah, okay. So yes, good question. This is a critical point. So Pharmacy First isn't a sort of isolated service. It's an integrated one. So if say a pharmacist identifies a red flag, for example, it might be a patient with a sore throat who also has difficulty swallowing and a muffled voice. So the protocol would requires them to contact the surgery immediately. So in practice, most PCNs will agree on a direct dial or a bypass number. So for pharmacies to use, so they can speak to a clinician, so they don't have to wait in the queue. Basically. So the pharmacist will provide a clinical handover, and the patient is then seen by the GP as an urgent addition. So this ensures that the patient doesn't then fall through any cracks, and it actually improves the safety by having two sets of eyes as well on that case. So hopefully that answers the question for you.
Thanks, Michelle. You mentioned the importance of the closed loop referral. How reliable is the tech for getting the consultation notes back into a clinical system such as EMIS or System 1? So does a staff member still have to manually code these, or is it fully automated?
So we've the integration part of things has come a really long way. When a referral is sent via a system such as CPCS or the Pharmacy First digital portal, the consultation outcome is sent back to the practice electronically. So in most modern setups using EMIS or System 1, these notes arrive in your, I think it's the workflow or workflow manager. So while a staff member usually needs to view and file the document just to ensure that it's been seen, the clinical coding or SNOMED coding is often attached to the document. It's using a tool like Referral Flow, which ensures that the initial referral is also logged correctly in the patient notes. So it just means that that loop is visible to any clinician that opens the record.
I think we've got time for one more question just before the question needs to finish. So we often find that patients can be quite insistent on seeing a GP specifically. Do you have any advice or tried and tested scripts for our receptionists to use when a patient is being quite pushy or feels like they are being fobbed off to the pharmacy?
Yeah, so as we talked about in the presentation there, so I think the secret here is the power of the positive alternative. So we kind of frame it in a different way. So for example, instead of saying, you know, we don't have a GP appointment, you need to go to your pharmacy, I think that leaves the patient feeling rejected. So instead we can sort of flip that slightly and change it to, I can get you seen by our clinical pharmacist who's a specialist in the condition. They can then assess you and provide the necessary prescription right there. Would you like me to book that in for you now? And then that's framing it as a sort of specialised, faster service rather than the consolidation price, which it might be thought of by the patient. So most patients are happy to accept that, and it's about moving it from, I'd call it a sort of gate, we're not gatekeeping that, we're providing a solution then for that patient. Hopefully that answers for you.
Thank you, Michelle. Apologies, we have had quite a few questions come in. We've not got time to go through them all today. But what we're going to do is we're going to email everyone the recording of this webinar. If you do have any questions at that point, please feel free to respond. We will be happy to help. And please feel free to share the webinar recording with any of your colleagues that you think might find it useful. But we do host lots of webinars every other month on lots of different subjects. So if you enjoyed today, if you follow us on LinkedIn, so you should see all of our webinars and any sort of interactive learning sessions that we've got going on there. So thank you so much, Michelle, and thank you to everyone for your time this afternoon.
Thanks, everybody.